So I would just like to rephrase the question as to, if we decide in an early breast cancer who does not need chemotherapy, and then we automatically know that who needs chemotherapy. So I think we just need to focus on whenever we get a small tumor node negative, to ask ourselves this question is that does this patient need chemotherapy, and then of course or systemic therapy, and then we proceed from there. Next, please. Uh, so why does this question come? Because even if you look at the very early trial of chemotherapy versus none, I can't use a pointer, but if you see at 5 years, around 50% of these patients, and at like half the patients, if we did surgery alone, they would be disease free at 5 years, and about 25% of these patients would be disease free at the end of 10 years. So if we just see that so many patients are disease free at the end of, I mean, even 1/4 of these patients are disease free at the end of 25 years, even without chemotherapy with surgery alone. So this was the CMF versus not trial, and even after 30 years of follow up, this has shown the benefit of CMF is definitely there. But what if I just look at it the other way around, that a small percentage of patients probably do not need chemotherapy. Of course, this is the trial which established the benefit of chemo, but if I were to look at it the other way around, saying that, of course, this has benefited a large number of patients, but probably a small percentage of patients do not need chemotherapy. And which is this percentage of patients? Next slide, please. Next slide, please. Yeah, so we all know that breast cancer is not a single disease, and the Sorley and Peru paper showed us that we have the various subgroups of these breast cancer subtypes based on the gene expression profiling. Next slide, please. So, if we understand that the classification is based on gene expression profiling, but we know that gene expression profiling, which is looking at the mRNAs of these tumors, is not possible in all patients. And therefore, what we use today is the clinical surrogates of this gene expression profiling. So, what are the clinical surrogates that we use to define these patients? These are the simple clinical surrogates of ERPR, HER2, and a Ki67. So, what is actually by gene expression a luminal A can be by these clinical surrogate what we call as a luminal A like. So, what is a luminal A like? So, that is basically patients who have a strong ER and PR positivity, HER2 negative, and low Ki67. So low Ki67 is usually a cutoff of less than 20%. So this is probably the subgroup of patients which do not need chemotherapy, but we definitely need to refine this subgroup further. The ones which are luminal B-like. So what is a luminal B-like tumor? Luminal B-like tumor is like an ER positive, PR negative, or low positive. So say I have a tumor which is ER8 plus, PR3 plus, HER2 negative, Ki67 30%. That is the kind of tumor which is going to be, which is like a luminal B like. See, most of these tumors are probably going to need chemotherapy. But as I said, that if next slide, please. So the present cutoff for Ki67 is around 20%. I think the previous cutoff was 14, but if you look at the recent ESMO guidelines also, it is 20%. So what we essentially need to know that in a hormone positive early breast cancer, so these were the initial trials of NACBP B20 where, they had checked CMF plus tamoxifen versus TAM alone. So there they have shown that, even after 10 to 12 years, about 20% of these patients uh, only will recur. So the rest 80 will not recur, and we can spare a large number of patients chemotherapy. And the entire question is to decide who needs chemotherapy and who does not need chemotherapy. Next slide, please. Okay, so to decide on this whether a lady with an early breast cancer needs chemotherapy, we have to look at three things. One is the classical clinical features. So we should not forget a basic clinical features is looking at age. Age less than 35 years is considered as a high risk factor because these patients, like even if it has shown by expression profiling, have a different profile as compared to a older patient. So what we are trying to say that a 35 or a 40-year-old ERPR positive tumor is different from a 70-year-old ERPR positive tumor. So the biology of this ERPR positive tumor in a lady who is young, so 35 to 40 years of age, would be more aggressive as compared to somebody who is 60 or 70 years of age and has the same 3 centimeter ERPR positive. So age definitely has a great prognostic significance. And of course, we know that node positive has a poor prognosis, higher tumor size has a poor prognosis, and same is that with grade. And next, of course, we will be looking at ERPR, HER2, and Ki67. And I will also be talking about the sorry molecular markers which are oncotype DX and mammaprint. Next slide, please. Okay, so this is what I just mentioned that, if you just look at the prognostic significance of age, so especially patients younger than 40, and those they are the ones which are at high risk of relapse, and same as with increasing tumor size and higher grade, they have a higher risk of relapse. Next slide, please. Next slide, please. Yeah. And same as I mentioned that those who are ER and PR positive, they are the ones who will be classified as luminal A type. And sorry, they are the ones who have a better prognosis as compared to somebody who is ER positive and PR negative. And if somebody is ER negative and PR positive, which is a very small subgroup, they have the worst prognosis. So just trying to say that when you are trying to decide whether or not this patient needs chemotherapy, we need to look at both the ER and the PR status. Next slide, please. Okay, so therefore we come to three facts. We have the clinical factors, we have the pathological features, and now we have the gene expression profiling. But if we just sit back and think, what are we actually looking at? When we're looking at the immunohistochemical markers, we are looking at the proteins or the expression of these genes. So therefore, if you look at the what proteins are we looking at? We're looking at ERPR, Ki67, and HER2. Now, if you look at the 21 genes, which the oncotype gene expression, which the oncotype DX is looking at, we see that they are looking for, proliferation markers Ki67. So I can look at, and other, of course, a whole lot of other proliferation markers. But essentially, they look at which, if I just look at IHC, then I'll be looking at Ki67 as a protein. If I look at the oncotype DX, then I'm looking at Ki67 mRNA along with other proliferative mRNAs. And of course, you have features for invasion. And similarly, you have HER2, which you can look by mRNA in a oncotype DX, or you can look at the IHC HER2. And say, so what I'm trying to say is that essentially the oncotype DX, the 21 gene expression profiling, is essentially looking at similar expression profiling as to what proteins that we are looking at when we do an immunohistochemistry. Next slide, please. Okay, so therefore, if you look at the oncotype DX, so if you subject this to an oncotype DX, we get a score. So less than 11 score, that is a low risk, that is 0 to 10 is low risk. Those patients definitely do not need chemotherapy, they can get only endocrine therapy. And the recent data has shown that even for those who have an intermediate score, that is 11 to 25, even they do not benefit really much from chemotherapy, because if you look at 11 to 25 with endocrine therapy alone, then it is again the 5-year rate is around 92%, whereas with chemoendocrine therapy, it's 93%. And the similar for overall survival, it's almost similar at 98%. So even for the intermediate group, the broad consensus is that they do not need chemotherapy. So it is only the high risk group, which is score more than 26, that is the one which needs chemotherapy. Next slide, please. So the other thing is that even they have integrated the genomic and the clinical score to say that if you have a, sorry, the previous slide, please. Previous slide, please.
Samir, previous slide.
Yeah, so what, yeah, the one after this, please. Okay, I think there's some, anyways, I'll just speak is that, so even if you have an oncotype DX 11 score 11 to 25, there if we have a clinically low risk. So if you have a clinically low risk patient, which is defined by less than 3 centimeter grade 1 or less than 2 centimeter grade 2 and less than 1 centimeter, but even then it can be grade 3. So if you have a clinically low risk tumor, then within the, or a high risk tumor, then within this intermediate group, we can decide who needs chemotherapy or not. So if a patient has a score somewhere between 20 to 25 or 16 to 25, that is the high intermediate group, and she is clinically high risk, she probably needs chemotherapy. Whereas if she is intermediate but clinically low risk, she does not need chemotherapy. Next slide. Yeah, so that is what I'm trying to say, that if they have a clinically uh, low risk, even if she's intermediate, then probably she does not need chemotherapy, especially if she's under the age of 50 years. Next slide, please. Yes. And a similar thing was looked at into the mamma print. So where they have seen that, if you have a clinically low risk, doing a genomic test really does not give any additional benefit. But if it is a clinically high risk group, then doing a genomic test might help you decide who does not need chemotherapy. Next slide, please. Yeah. So if I have to just put it as to how will you go, so first we are supposed to look at the clinical risk factors. If she is clinically low risk, uh, really no additional benefit of doing a genomic test. So what does this mean? This means that if I have a 60-year-old lady who has a 2 centimeter grade 1 tumor, probably this lady does not need any further genomic testing. And of course, she is ERPR positive, strong positive, HER2 negative. This patient does not need chemotherapy, and you can decide based on clinical factors only that to put her on hormone therapy. But if I have a high risk tumor, clinically high risk tumor, so who's a clinically high risk tumor? A clinically high risk tumor would be, say, somebody is the same 65-year-old lady, but now this time she has a 3 centimeter grade 3 tumor, LV. So this is probably a clinically high risk. And then we do a genomic testing for this patient, and of course depending on what is available, and if she is genomically low risk, then you can offer her no chemotherapy. Whereas if she is genomically high risk, this is the patient who would benefit from chemotherapy. So I think this is the kind of broad algorithm that we can follow. Next slide, please. And in case, like many of us, we do not have access to uh, the Oncotype DX or the Mammaprint because of the huge expenses, can we use some clinical surrogates? What clinical surrogates we can use is the IHC4, because as I mentioned, the IHC4 is also looking at similar things but on the protein. So the IHC4 is nothing but ERPR, HER2, and adding Ki67 to it. Although the original IHC score actually puts all these factors into an mathematical model and then gives you an output. And if you see, there is a good correlation between IHC score and the Oncotype DX. So clinically, even if you do not have access to that entire IHC4 score, and we can tentatively take a binary cutoff and use this. Next slide, please. And even if you look at Predict Online, which is a online available tool which uses clinical factors like age, number of lymph nodes, tumor size, grade, and whether it was screen detected or not, because most of our tumors are not screen detected, and Ki67. So these, sorry. So these are the factors which, if we take into account, we are able to predict reasonably certainly whether a patient needs or does not need chemotherapy. Next slide, please. Okay. So if I just have to summarize that, if I have a clinically low risk patient, so that is a strong ERPR positive, HER2 negative, postmenopausal lady who has no lymphovascular space invasion, that is a patient and a grade 1 or grade 2 tumor. She does not merit any further genomic testing and probably can be put on hormone alone. However, if you have a clinically high risk, so as we said, 3 centimeter grade 3 LVSI positive, if I have an access to doing an gene expression profiling, definitely we should go ahead and do a gene expression profiling and base our decision on that. However, if we do not have an access to a gene expression profiling, we can still probably make a reasonable guess And that guess would be based on what factors? That would be based on the fact that if, depending on what is the age of the patient. So if she's a 40-year-old with a 3 centimeter grade 3 tumor, LVSI positive, clinically I would, without access to genomic profiling, I would put her on chemotherapy, because age itself is a high risk factor. Whereas if the same lady is a 75-year-old diabetic hypertensive ischemic heart disease, and has a whatever same 3 centimeter grade 3 tumor, probably her risk of non breast cancer mortality is higher, and that is a patient where I would probably put her only on hormone. So the decision for chemo is not only based on tumor factors, but it is also based on patient factors. So I think those are the kind of things that we would use to decide whether to put this patient on chemo or not. uh, Next slide please. And just this was a recent trial where which was discussed at ASCO this year, and this was whether, very old patients like 70 to 80 years of age, whether and if they are HER2 positive, whether one could give only trastuzumab monotherapy. Of course, this is only one single trial, but then this gives us an option for these very old patients with multiple comorbidities of giving only trastuzumab, and if hormones if positive, without chemotherapy. But this is a select group of patients who are old, early breast cancers. This was a I mean, this did not prove. There is definitely an additional benefit of chemotherapy, but that is marginal, and especially if the patient has other comorbidities, one could consider trastuzumab alone. So that is just a thought in this area. Most of the triple negative breast cancers, of course, all of them would need chemotherapy. Next slide, please. So I would say that, in early breast cancer, we have to select our patients, ERPR positive, HER2 negative, based on clinical pathological features. And of course, if genomic tests are available, we could consider them in clinically high risk groups. HER2, very old patients, multiple comorbidities, monotherapy is an option. I would still not say that that is the standard of care, but that is some option that can be considered based on the present study data. Thank you. Lastly, please. Yeah. Thank you very much, and happy